Catherine, as people are coming in, and before we start discussing things specifically, I just want to reiterate some of the things that we were discussing earlier. That this is kind of experimental to do this for me in an electronic medium. I really treasure it in a face-to-face medium. And for those of you that have been involved in this before, we like to rearrange the chairs in a circle and sort of take away some of the hierarchical aspects of it, and really have it as sort of a sharing of experiences. And I do really appreciate people sharing, deeply personal stuff. And it, in a way, it's going beyond the normal HIPAA constraints on how personal medical information is handled. But we have a trusting community here. I do want to, though, say that I shouldn't be giving medical advice in this context. I mean, it's not a way of practicing medicine. So I'd like you all to sort of formulate your questions in a way, not what should I do? Is my doctor doing the right thing? Formulate your questions more in a way that you think would be useful to multiple people in the group, and try to generalize it a little bit. And I'll try to stick with that philosophy rather than, I don't want to be in the position of second guessing your doctors and your own treatment choices over the years. That's not really what we're about here, but we're to share experiences and knowledge.
I'm going to go ahead and, if you don't mind, I'll go ahead and just get us officially started.
Okay.
Okay. So this is session 243. Ask a doctor your questions about medullary thyroid cancer. It is a recorded session. We are being recorded. My name is Catherine Wall, and I'm a ThyCa volunteer. I'm also a medullary thyroid cancer survivor, 23 years. And before we got started, Dr. Ball and I were reminiscing about, I saw him present at the 4-H Center back in either 2000 or 2001 is where I met him. And he's been a real trooper over the years to meet with us and answer our questions. Dr. Ball is an endocrinologist at Johns Hopkins Medicine in Baltimore, Maryland. He's an associate professor of medicine specializing in thyroid cancer, medullary thyroid cancer, and multiple endocrine neoplasia. He's active in developing new therapies for medullary thyroid cancer, and he has been just a phenomenal friend of ThyCa and supportive of this community over the years. And I just personally want to say thank you. And I will just basically, I think, just turn it over to you now. If you need my help, I'm here, but otherwise I'm going to turn off my video.
Great. Thank you, Catherine. So the two questions that I promised we'd start with, first from Rick, and again, this was worded somewhat as a personal advice kind of thing. I'm going to rephrase it slightly. The question is, with a long-term stable calcitonin value in the 600 range, is it necessary to have regular imaging, such as a PET scan? And I think it is a good idea to touch base with imaging on a regular basis in that sort of situation. PET scan would not necessarily be my personal choice for reasons that I mentioned at the prior session. But I think when the calcitonin has long-term stability, then the frequency of imaging can go down. So I think I'll leave it at that. The second question is from relates to a question of a patient who has a known RET M918T mutation with a rapid calcitonin doubling time and mediastinal tumors, and a pretty high calcitonin and CEA. And it relates to when is the appropriate time for starting a drug like Retevmo, and what are the disadvantages, if any, of starting it early? And I'd like to focus on that aspect of the question rather than, whether in this person's individual situation is for inoperable disease. In that case, is it worthwhile? I would say that this is a prime question in MTC, maybe the most important question, or one of the 2 or 3 most important questions right now. Um, the We know that in some cases, resistance to the highly selective RET inhibitors can emerge, and we've seen it in our own cases. Dr. Worth at MGH has reported a few examples. So it is happening. And also, although these drugs are well tolerated, they do have side effects. So my philosophy has still been to consider keeping the powder dry, so to speak, if we don't anticipate that there's going to be dire consequences from the cancer in the next few years. Now, that's not necessarily supported by data yet. We don't really know. And you could take the alternative point of view and say, maybe there's less chance of resistance mutations emerging if you treat the patient early, where there are fewer tumor cells. There are studies, for example, there's one planned at MD Anderson with Dr. Hu, I believe, where they're considering treating patients very early, selecting them mostly on the basis of the increased calcitonin, short calcitonin doubling time. So my personal approach has been more trying to keep the powder dry, thinking that resistance may become a problem as longer exposures to the drug are seen. But I certainly don't hesitate to start patients who have, significantly progressing disease and, a doubling time under 6 months and, extensive metastatic disease. I wouldn't have much hesitancy in treating. But that really is a prime question. At what point do you intervene? We can discuss this a little bit more, perhaps. All right. So that's it for the holdover questions.
Thank you. Yes. So I have a KRAS mutation in advanced MTC, and wondered what's on the horizon with KRAS as far as treatment, because I've been hearing some things, and I'd love to know what you know about it.
Yeah, great question. So, as you may know, the National Cancer Institute had a major KRAS initiative to develop drugs that would inhibit KRAS. Let's take a step back. KRAS is one of the alternative mutations to RET as a tumoral mutation driving MTC, and it was about third most prevalent in our Hopkins study in tumoral RET mutations. The NCI had a major project to develop KRAS targeted therapies, and it has resulted now in promising drugs, I believe, for 2 specific KRAS mutations. I'm not entirely up on the individual ones and whether those translate to utility in MTC. But the main market for this really is lung cancer and GI cancers. And these drugs are pretty successful. So those KRAS-directed therapies could be an exciting new option. Short of that, there is also some activity for cabozantinib and I was involved in the phase 3 study of that, and we did a breakdown of the different mutational types, and it turned out that patients with RAS mutations did benefit some from cabozantinib. So
I am
think,
on it. I
okay.
am on it and getting great benefit.
Wow. Okay. Could I ask what, this is very particular information, but can I ask what dose you're taking?
I'm only taking 40.
Okay.
I tried 60 and couldn't tolerate it. So
Yeah.
for 3 years, I've been on 40, and the lesions are stable for 3 years.
Yeah.
And they were not before that.
Yeah. So I think your experience is sort of emblematic in a way. There's big difference between 40 and 60. I've seen that as well. And in the phase 3 clinical trial of cabozantinib, there were it was a relatively small number of RAS mutation patients, both NRAS, NKRAS, and HRAS, all three. But they had improved time to progression compared to patients assigned to placebo. And interestingly, for patients who did not have RAS or RET, that benefit was not seen. So it's an interesting kind of subgroup improvement.
Yeah, I was assuming it was from the VEGF activity, but I don't know.
Hard to know. Mm-hmm.
Yeah, thank you.
Great. Okay, thank you.
Yeah, sure. Hi, Dr. Ball. It's Wendy from California. What ongoing and or upcoming trials are you the most excited about? Selpercatinib has kept my scans mostly stable for 5 years after a decade on vandetanib and a little bit of time on cabozantinib, which I didn't tolerate. But my calcitonin is back in the range it was in before selpercatinib. It's about 135,000, and diarrhea is still a problem. So I'm looking ahead at what's the next big thing and wondering what you like, what we should look at.
Yeah, well, good question. There's a very provocative trial at the University of Pennsylvania that uses CAR T cells directed at medullary thyroid cancer. So this is a pretty aggressive form of immunotherapy, and it instructs the body's lymphocytes to react against a cell surface marker, which is relatively specific for MTC. I say it's a very aggressive treatment because for those reactive lymphocytes to sort of take over in the body, there has to be a depletion of the lymphocytes otherwise. So there's the immune system is temporarily really hindered, and then the lymphocytes that have been instructed to attack this marker are reintroduced and take over. And I've not heard any results from this to date, but it has me intrigued. And it would make sense for somebody with advanced disease, not somebody with low-level disease, I think. This approach has been super effective for certain hematologic malignancies like B-cell lymphoma, but has been slow to take off for solid tumors. So that's one I've got my eye on. The other thing to look at, I think, Wendy, would be, I would if you have a tumor that is a particular one, which is obviously growing out in the face of selpercatinib or Retevmo, it's worth biopsying that and doing a mutational analysis on that tumor. So there are, becomes somewhat of an arms race to identify the resistance mutation and get on a clinical trial or a drug which blocks the mutation. But that approach can really work. So I'd encourage you to consider a tumor biopsy. Some oncologists do this with a liquid biopsy, but MTC, to my knowledge, hasn't behaved or cooperated too well with the liquid biopsies so far. Okay.
Thanks.
Sure.
Yes, I'm trying to connect on Zoom, but can you hear me?
Yes, can hear you fine.
Yes. So the question that I wrote, you've partially answered with the CAR T cells, but I was wondering what was happening with the new trial for a drug after Retevmo stops working. I've been on Retevmo for 4 years now, and it is continued to work, but my CEA is of climbing higher every month. So I believed that there was like a LOXO2 or something, or another step of a drug that they might be doing a trial on, but I don't have any information on that.
Ellen, I'm sorry, I'm not knowledgeable about that.
Okay.
Yeah, I just can't tell you anything.
Okay. All right, but thank you so much.
Sure.
Okay.
Okay. Lisette in the chat, Lisette asked a question: what do most MTC patients actually die of? So that's a good question, and the obviously a lot of MTC patients don't die of medullary thyroid cancer, even if they have persistent MTC. They die of things that people normally die of. But I'm assuming from the context of Lisette's question, maybe she's saying, what is if you are going to die from MTC, what is how does it go? What happens? So I would say that in my patients that have passed away from MTC, the most common way is probably dying from an infection after kind of losing their appetite and having a wasting illness, particularly when the liver is involved with a lot of tumor. It tends to reduce the appetite, and then people's resistance goes down. So I guess that's the best answer for that. But different routes are possible.
Dr. Boss, someone wanted to know, what bike do you ride? Did you talk about that at your last session?
Well, I actually went for a ride this morning on my mountain bike on a trail. I've got a Scott mountain bike, and then I've got a Cannondale road bike. Are there other cyclists in the group? Great, Bill. Thank you. It's a pretty good exercise when you're over 60. It's a good way of controlling your weight. Burn a lot of calories that way. Are there any patients in the group with early stage MTC who are kind of new to the MTC world and are a little bit unsure about what's going to happen? Okay, Lisette said yes, and then 2 other participants raising their hand. I think oh, fans and cyclists. Okay, maybe they're raising their hand for being cyclists. I think first off, Lisette, it's great that you're in ThyCa. I mean, that's what I recommend to my patients, because being in a community like this is priceless. I think one of the things that's you have to learn early on in a group like this is the the heterogeneity of the disease. I mean, we lose, every year we lose some of our ThyCa medis, but then there are other people that are just have a very mild case of medullary, and it can be indolent. And so there's this really wide range of potential outcomes, and I think early on it's difficult to see, where you are in that scheme. So I hope your experience in the meeting, you can appreciate. You don't get as much chance to interact with other members in this format, but I hope you can begin to sense where you kind of fit in the scheme of things, and understand that. Let's see. There's a question from Tracy. Okay, so this is really related to MEN2. Tracy, do you want to speak this question, or do you want? Would you rather just have it?
Hi, I'm happy to talk about it.
Yeah.
I have 2 kids and they're under 10, and we're just waiting to see if any numbers change, and when is it a reasonable time to act?
Yeah. So, Tracy, you have a known RET gene mutation that the 2 children share. Is that correct?
Yes, I've got 4 kids. 2 of them, the older ones, have had their TTs done, and they were much older, in their later teens. And the younger ones, we're just watching, waiting, but I just don't know when to act. And we're 609.
Yeah. Catherine had a good suggestion in the chat about a session which is specifically for pediatric MTC and MEN2. So that will definitely have more detail about this topic. I would say that in a general way, there's been an evolution in clinical practice for this, that in the early 2000s, we tended to do prophylactic thyroidectomy at a pretty young age in all but very low risk mutations based on what the germline mutation was. There was an influential paper from Italy showing that, with the exception of the M918T mutation, the one associated with MEN2B, that the outcomes could be very good if the surgery was delayed to the time when there was a positive calcitonin level.
Mm-hmm.
In that Italian paper, they used a slightly more sensitive procedure than we have available in the US. They used a pentagastrin stimulation test, which we don't have. But I think the current generation calcitonin assays are quite sensitive and approach the sensitivity of the pentagastrin stimulation. So, definitely the kids should have, annual calcitonin levels, and strongly consider prophylactic thyroidectomy if those are becoming positive, as a general, the general guidance for that. But some families do choose to do a prophylactic thyroidectomy before that. The idea is that they, don't want to, delay surgery to the point where there's lymph node involvement or spread outside of the thyroid.
Yeah.
It's still a topic in evolution, I'd say, and I think that session 135 is best to get some further guidance on.
I'll definitely check it out. Thank you for your help.
Okay.
Well, Bill actually put his question in the chat, in the Q&A, so I can read it in case but he can pop in if he'd like. It said, particularly for the newbies, how would you compare treatment options for MTC now compared to 5, 10, or even 15 years ago? And how does this give you hope as a doctor for the future of advancements?
That's a good, yeah. That's an interesting question. Catherine and I were sort of reminiscing about how things have evolved since the days when ThyCa was in the Washington 4-H Center. And I remember when, at that time, there was really no systemic treatment involved at all. Dr. Martin Schlumberger in Paris had a study that involved a product from a Mediterranean sea squirt a company, a biotech company in the south of France or in Barcelona had come up with this biological product. And that was literally the only thing going at that time was this ridiculous biological product. So things have changed utterly in terms of treatment of metastatic disease. And the development of RET-EVMO and other highly selective RET inhibitors, I think, has really been the key inflection point. If I could just sort of reminisce about when I learned about that and how the field kind of changed at that point. We had an ITOG meeting at Duke about 10 years ago now. ITOG is the International Thyroid Oncology Group, and there was a presentation from the company that was developing it prior to Lilly. And they described this highly selective drug as an alternative to vandetanib, which was less selective in inhibiting RET. It also inhibited VEGF receptors. And we had always thought, well, maybe that's a good thing because those are probably also relevant in thyroid cancer. So we saw that as a feature, and the presentation made it clear that really that was not a feature but a bug. And in fact, that rationale has been totally correct, that we're now able to dose patients at a way that inhibits RET greater than 90% inhibition over a 24-hour day, as opposed to maybe 50% inhibition. And because the expression of RET is so limited to MTC cells in adults, we can do it with low toxicity, whereas the toxicity for the less selective drugs was higher. So that was a major inflection point with the selpercatinib and prseltinib results. Yeah, I am hopeful that there will be future developments of along those lines, and part of it will be identifying the additional mutations that are involved. Filling in the so-called dark matter, which is beyond RET and the 3 RAS genes. That's going to be important. The question that was asked earlier about being able to individually target the RAS mutations, that's going to be important. Maybe getting effective immunotherapy, that will be valuable. So I think progress keeps coming. A major challenge going forward will be the emergence of the resistance to selpercatinib and prseltinib. That we have lessons from other cancers and other highly selective inhibitors, where a highly selective inhibitor sort of speeds up the tumor evolution, if you will, and selects for those cancer cells which can overcome it. So that's going to be a challenge. But yeah, I think there's great reason to be optimistic. So that's sort of like a big picture. I mean, there's been tremendous progress. I also think we're doing better just in terms of the basics of tumor imaging and surgery too. I think we're a lot more effective, and we've got better knowledge of the natural history and can use those standard tools more effectively now.
Thank you. We have another really good question from Bill, and I'll read it for you. It says, how
Okay.
is staging for MTC different than staging for other cancers? For example, we see many in our MTC group with stage 4A, 4B, and 4C, yet many tend to live full lives and for many years, whereas so many others with stage 4 and another cancer typically pass away fairly quickly. Again, this would really help our newbies with the fear aspects of having a stage 3 or 4 when diagnosed with MTC.
Yeah, great question. I think that's right. And there's some discussion in the MTC specialist community that the TNM staging does not serve MTC very well. For a couple of reasons. There are these other risk factors that just are not. What staging is supposed to do, and the questioner understands this, I think, is it's supposed to provide a prediction of risk of dying from the cancer, and to create survival curves at the different stages, which are clearly separate. And it doesn't really do that good a job in MTC. And the questioner is right. There are plenty of patients with stage 4A and even 4C with very long survivals. And some people initially assigned stage 2 or stage 3 can die if they have rapid doubling time. So there are, in addition to TNM, there are kind of non-TNM risk factors. The most important of those, I think, are the M918T mutation and the rapid doubling time, and then those very rare patients that are calcitonin poor. So those are kind of additional factors that we think about. But yeah, you're absolutely right. It's kind of easy to get to stage 4A with the lateral lymph nodes, and that doesn't necessarily mean you're going to do badly with MTC the way it would with certain other cancers. I hope I captured your question there.
I think that was a good answer. I think that was very helpful. There's another question.
So in other words, don't be too freaked out if you're stage 4A, and really even 4C, even distant metastasis. MTC is a little bit like papillary thyroid cancer in that you can have distant metastasis and still have indolent disease. It does tend to grow out with time, but not always. And then I would say just to riff on this topic a little bit more, at the low end, it's just extraordinary to me how indolent this disease can be sometimes. And let me just give you a little anecdote that illustrates this. When we first started doing RET mutation screening, an index case had the RET mutation called V804M, which is kind of known to have a variable course. And we started identifying elderly relatives of this patient who, even in their 80s, had a calcitonin of 8 or 10. And there were quite a number of these people. So this is, in those people, this was the weakest oncogene you could possibly imagine. I mean, it's kind of stunning. I mean, they had something. The calcitonin wasn't normal, but it was just minimal. So, the disease can be very indolent at times.
Okay, so we have a question in the Q&A from Peter, and he says, "Thank you very much for answering my previous questions." I think that's the one you started with, maybe?
Yeah.
He says, "I live in Europe and very much appreciate your expert insights. General follow-up. Appreciating that you like to keep the TKI option open for us as long as possible, what sort of other treatment options are available for fast-growing RET tumors in the mediastinum? Are multiple surgeries in the mediastinum an option? Any radiation or ablation options that could be looked into? Thank you again."
Yeah, good question, Peter. I recognize that ties into your texted question from the prior session. So the mediastinum can be targeted with stereotactic radiation in some instances. So paratracheal tumors, a little higher up, can be targeted. When the tumors are close to the heart or the great vessels, they really cannot be treated with stereotactic radiation. So that's a problem. I'm not aware of radiofrequency ablation or other techniques that can be employed in that instance. Deeper mediastinal disease usually means systemic therapy. There are some problems with watchful waiting for bulky mediastinal disease. So there's a feared complication if the lymph nodes in the chest become too big, called superior vena cava syndrome, where the lymph nodes squeeze the superior vena cava that provides the blood return from the head. And that can lead to kind of facial venous congestion, and poor blood return from the head is a bad thing, of course. So I think growing significant mediastinal disease, if it's not accessible to stereotactic radiation, then systemic therapy like rotentanol would be a good option, perhaps. Let's see. Looking back on the chat list, Margaret had one to everyone. A question about staging. Do staging levels refer to the time of diagnosis, or can they apply to one's current situation? So yeah, it becomes updated with one's current situation, and so that the first time the staging is done is with the original pathology report, because that's where you know the extent of the local tumor invasion, and where you know what lymph node areas are involved in. But oftentimes the pathologist signing that out will say, T something, N something, and MX, because they don't know the mutation standpoint degree. So the distant metastasis, excuse me. So that information then gets upgraded as time goes on.
Dr. Ball, there was two anonymous. I wasn't sure if we covered those. Are you hearing any progress with finding alternative options for folks with HRAS mutations besides Cabo or Vondi?
Yeah, that's a tough one. HRAS mutations, there was a historical approach which was kind of promising, but is no longer available for thyroid cancer. This is a drug called tipifarnib. I don't know beyond Cabo. We don't really know if much about vandetanib and HRAS. So that would be another thing to consider. But yeah, it's a problem, I would say.
Okay, and from Donna, she was questioning, I seem to choke easily since my total thyroidectomy and right neck dissection. Is this common?
Yeah, let me address that. So there, I guess there are different levels of swallowing dysfunction after neck surgery. I would say the majority of patients, and if I were looking around the room, I could check this with you all, but I would say most people don't swallow totally normally after having their thyroid or neck surgery. There's an increased awareness of swallowing that's kind of with you for the rest of your life, even after the original surgery. So but that sort of becomes the new normal for most people. In addition, there is acute swelling that may last perhaps 3 months after the surgery, and that after 3 to 4 months, things tend not to improve from that. Then there's another aspect to it, which is referred to as aspiration. So if you have a vocal cord injury, and it's really a vocal cord malfunction due to injury to the nerve to the vocal cord, the recurrent laryngeal nerve, that can cause aspiration, and it's literally food or liquid going down the wrong pipe because the vocal cords are unable to close totally. And so for persistent choking after surgery, it's a good idea to see an ENT doctor, if possible, a subspecialist called a laryngologist, who would be able to do a sophisticated look at the vocal cords and see if they close properly. Many folks think, well, I've got a voice, so that shouldn't be a problem. But some people surprisingly have a pretty strong voice and have a vocal cord not working. So really, I think the next thing, if it hasn't been done already, would be to see an ENT specialist who, if possible, a laryngologist.
Hi, Doc. Thanks for being so generous with your time.
Sure.
I had my first surgery, new to the information, new to all that, and just wound up at a very good surgeon, but not an MTC specialist. And I don't know how that's affected my outcome, or if it would have been better if I'd been. I think it would have been better, but we keep hearing this story. I keep hearing newbies joining. For me, it was 20 years ago, and doctors still aren't referring MTC to MTC centers of excellence. And I'm just wondering what we can do as a group, or what your thoughts are on how we can get people to not have, the inadequate first operation.
Yeah. I think it's, I think from the standpoint of patient activism, it's, doing everything possible to raise the profile of ThyCa, including, making it something that people will, get on their Google hit when they, inevitably look up medullary thyroid cancer after their biopsy comes back, on the first night. But I think an even more effective intervention is really needed on the part of the subspecialist surgeons, both on the endocrine surgery side and the ENT side. So there aren't studies showing outcomes based on surgical volume, and it mostly relates to complication rates, showing that high volume surgeons have lower rates of recurrent nerve injury and surgical hypoparathyroidism and other adverse outcomes. But I think that that kind of research and outreach amongst the surgical professional groups needs to go a little farther, so that it sort of somewhat breaks down the entrepreneurial and hero culture in the surgical community to refer to their colleagues. I mean, I think there has been some progress in that, honestly, with more surgeons being attached to health systems as opposed to being, sort of freestanding entrepreneurs, and more surgeons on salary rather than being paid by the operation. I think that helps too. But we still clearly have a long way to go compared to, a centralized healthcare system, like, for example, in France or Germany, where, it's just expected that you send your patient to a center of excellence. It's really, Didi, you can probably testify, and other people can, that, when you're faced with the diagnosis and you're referred to a surgeon, it's a very difficult psychological position to be in. You want to trust the person whose care you've been placed in, and it's creates a lot of internal conflict if you're questioning that, or even seeking a second opinion at that point. So that the natural tendency, I think, is for people to go where they're referred. I mean, we do see plenty of examples of, outside ENTs, outside general surgeons referring people into our center for subspecialty care. So it's not the word is getting out, but it's not as well as it should.
Agreed.
Can you reflect on the psychology that you went through? Because I'm interested in this. What patients go through when they get that diagnosis, and how you kind of navigate.
Oh, sure. Yeah. And it was very much sort of exactly how you reflected it too. We got a diagnosis. We were referred to a surgeon, and of course my initial reaction is, get it out, get it out, get it out, right?
Yeah.
That kind of visceral, I want it gone.
Right.
And so we went to a surgeon, and thankfully at the time, I had a sister-in-law who was a surgeon, and I involved her, in getting kind of a second opinion, and she did a little research on her own, and she said, "You're coming to my partner, who had a lot more volume of thyroidectomies, though he wasn't an MTC specialist." And as a result of that, they did the first surgery. They took out quite a few nodes. Quite a few of them came up positive. So we went right back and did a neck dissection, a more thorough neck dissection, like 2 days later, which has resulted in some morbidity in my neck. But at the same time, at the time, it seemed like the right thing to do. And again, if we had, waited just another month and let her do a little bit more research, we might have wound up with probably Dr.
one
Foley,
operation,
someone like that, and one operation. And
Yeah.
maybe even if it had been an expert who'd known where to look and how it kind of tends to hide and where it tends to kind of go. And this is a conversation with Dr. Moley, afterwards. I've since had, and then in 2009, I had another surgery. And so I've had it for a long time, and I'm very happy with, the fact that calcitonin has remained fairly inactive. And we've only had 3 surgeries, but I'm facing making that decision about number 4 right now. And if I had any wish, it would be to make sure that I don't hear this kind of story again from anyone else, because this is a sporadic case, and I'm just rambling on here. This is a sporadic case. So if it had been properly handled with about a 2-centimeter tumor and not having left the neck yet, I really think, a good competent surgeon would have, or a good competent MTC surgeon would have maybe changed sort of my long-term.
Yeah. And there's certain pitfalls that your care sounds like it's been fine, but there's certain pitfalls that are just sort of egregious. And one of them is the practice of excisional biopsy. It doesn't sound like it would be bad, but it sort of violates the integrity of the lymph node compartment and makes it much more difficult for the surgeon to do a comprehensive procedure, when the time comes. They shouldn't be doing a berry picking. They should do it all together. So the biopsy should be done by a fine needle, not an OR procedure. So, right. A few more questions have come in on the chat. Let's see, Margaret, if someone develops swallowing issues a few years post-surgery and still has high calcitonin levels, is this indicative of disease even if scans do not show any growth? Would an ultrasound be useful? Yeah, that's a challenging problem, Margaret. A little bit unusual for late swallowing problems to happen. I mean, I always ask about that in the interval visits, but the answer is usually no. And I'd say when it's yes, most often it's not recurrent cancer, but something more functional. I usually send people to I do detailed neck imaging, both neck ultrasound and CT neck. I do a test called a barium swallow. Basically, it's the fancier modern version of a barium swallow, and I refer them to a swallowing specialist. But there are other reasons that it could be, from something as simple as acid reflux to more complicated GI problems involving the esophagus or esophageal narrowing that need an esophageal dilation. It goes well beyond, sort of endocrinology issues. So my practice is to do those kinds of tests and then refer the patient on to a gastroenterologist who specializes in swallowing issues. But yeah, an ultrasound would be helpful, although really the problems are often deeper lying than the ultrasound would see. The ultrasound can barely see the esophagus, for example. Okay, let's see. Kathleen, I think. Do you think it's necessary to see an MTC expert surgeon for a preteen kid with MEN2A that is having a prophylactic thyroidectomy to prevent MTC, or is a pediatric surgeon with a specialty in thyroid cancer? So it's really unusual to have a pediatric surgeon with a specialty in thyroid cancer. And much of the, because papillary cancer and so on are so rare in the pediatric age group. I think it is a good idea to have an MTC expert surgeon for MEN2A, because there really are specialty issues relating to the management of the parathyroid glands. The child is a preteen, so it's a pretty small thyroid gland. The chance of nerve issues is pretty significant. So I think that's the kind of person that should go to a center of excellence, even though it's prophylactic. There still are some pretty important issues, and the ATA guidelines are unambiguous about this, that patients with undergoing prophylactic surgery should go to a center of excellence for that.
Dr. Ball, it is 2:00. We want to be respectful of your time. I don't want to keep you over too much. Really do appreciate your time today.
Sure.
We could keep you. I was telling Dr. Ball before we started that I remember him being in Chicago, and somebody went out and ran and got him some lunch because we didn't give him a minute to go get lunch in between his sessions. And he's trying to eat his sandwich while we're all crowded around him trying to ask all these questions because he's so generous with his knowledge and everything. And maybe sometime in the future, we'll be able to be in a room together again and
Yes.
bring you some better food this time. But anyway, I think this format worked out pretty well.
Pretty
it's the
well,
largest attended session that I've been to this year for Medis. So anyway, we do totally appreciate your time.
Sure, you bet. And yeah, I hope we can have a hybrid format in the future so that the people that can attend in person can share a little more comfortably, and folks that can't travel easily can still participate. I mean, that get the best of both worlds, perhaps.
I hope so too. Well, thank you
All
guys. Thanks everyone.
Thanks everyone for participating and sharing.